Okay. Hello, dear doctors, dentists, and fellow colleagues from all around the world. I'm Dr. Adi Brad, and on behalf of a Canadian confidentist and a bona fide payment, I want to welcome everyone to today's lecture. So today our lecturer is Dr. Kouramas, who is an oral surgeon and implantologist from Greece. He is very well known in this field of periodontal regeneration and GBR around the implant. So today's lecture is going to be on the topic of platelet-rich fibrin or PRF. I believe it's going to be a very informative one. So without further ado, I ask Dr. Kouramas to start his lecture. Thank you and good luck.
Hello, everybody. I hope you're doing well. First of all, I would like to say that it's my honor to be a part of this great series of lectures organized by Canadian. So once again, thank you, Canadian, for the invitation. Today's topic is about the platelet-rich fibrin, the so-called PRF. I will start with a little bit of I will start with a brief history of the platelet concentrates, which is a wider family in which PRF belongs to. So, as we know from biology, the gold standard for in vivo healing and regeneration requires interactions between some cells, like platelets, leukocytes, stem cells, and also a scaffold made by fibrin and some growth factors. So altogether, they promote the cell proliferation, cell differentiation, chemotaxis, and angiogenesis, which are very important in the processes of regeneration and healing. So this need and need to improve our clinical results led some clinicians and researchers to the development of certain biomaterials that are derived from the patient's own blood. As a result, we came up with the first generation platelet concentrates. The first one was the platelet-rich plasma, the very popular PRP, which was introduced by Marx in 1998. And 1 year later, the plasma-rich in growth factors, the PRGF, which was described by Anitwa. But these first generation platelet concentrates had certain disadvantages. The first one was that they were technique sensitive. There were several steps in which the operator had to do something. So there were several steps in which something could go wrong. So we can say that they were very operator dependent. As a result, they were also time consuming. And the most important disadvantage is that there was the need for additives like anticoagulants and some activators like bovine thrombine and calcium chloride. You can see that bovine thrombine is an animal additive, which means that there was also a low risk of disease transmission, very low, but still existed. So all these problems were solved with the introduction of the second generation platelet concentrate, the platelet-rich fibrin, the PRF, which was firstly described by Dr. Joseph Sukrun in 2001. And its aim was the simplification of the PRP protocol and, of course, the removal of the additives. So what is a PRF? As we said, it's a completely autologous fibrin-based biomaterial that comes from the patient's own blood. Please, for those that you're not familiar with PRF, keep in mind that it's a clot, but an optimized clot because it is produced after the centrifugation in which we are putting the settings. So it has an ideal architecture and it is charged with some cells that are in the ideal proportions inside this fibrin matrix. So the PRF is charged with platelets and leukocytes, which both secrete growth factors, which are the the key factors of the PRF's way of action, and some stem cells. About its composition, about the platelets, they play an important role in hemostasis and healing. After their activation, they are trapped into the blood clot, and they degranulate, secreting growth factors, chemokines, cytokines, and other mediators, which they attract cells from the tissues, and they facilitate angiogenesis and healing. About the growth factors, as I already said, they are secreted by the platelets and the leukocytes mainly. We have a lot of them, more than 150. I will not stand more here. Please keep in mind that they are the key factors of the PRF's way of action, and each of one of them has a specific action. About the leukocytes, they secrete again growth factors. For example, monocytes, they play an important role in bone regeneration, and generally they are a part of our immune system, and they protect us from infections and foreign bodies. The mesenchymal stem cells, PRF is a carrier of these stem cells, which they play an important role in bone regeneration. So over the years, several PRF protocols were described in order to improve the proportions of different cells inside this fibrin matrix. And there are also some different protocols for different PRF forms. We can have either a solid PRF and also a liquid form of PRF. I already told you that PRF is a clot, but sometimes we can stop the centrifugation a little bit earlier in order to take the PRF in liquid form, which is a liquid fibrinogen. You know, the clot is fibrin. So this is the most common forms of PRF: the LPRF, the APRF, the advanced PRF, the advanced PRF plus, and the liquid forms, the APRF liquid and the IPRF. About the PRF's advantages, as I said, it's completely autologous. It's a natural biomaterial. It is safe. There is no risk. And of course, there is no risk of rejection or foreign body reaction. Easy handling, both liquid or solid forms, and is easily managed in handling. And also an important advantage is that it can also be sutured. Compared to the first generation platelet concentrates, it has increased clinical performance, which means that there is a release of growth factors for more than 10 days. It's also economically advantageous because, as we will see later, we can use this PRF as a barrier membrane, so we can avoid buying a commercially available collagen membrane. And there are completely no contraindications. It can be used in every patient, and especially in high-risk patients like diabetics and smokers, which usually they need a boost to their healing process. About its disadvantages, it has to be prepared and used really quickly because, as I said, it's completely autologous. There are no anticoagulants inside, so we have to be really fast between the blood drawing and the centrifugation. And the liquid forms, we have to use them really quickly because otherwise they will start to clot. It lacks a little bit in rigidity and stability and is resorbed in 7 to 14 days. That's why by some clinicians its usage in GBR is questionable. We will discuss it later. And of course, it's not available in large quantities because it comes from the patient's own blood. Let's see now step by step the whole procedure. First of all, it's the blood drawing, so we have to draw some blood from the patient. Then we have to do the centrifugation, and then we have as a last step to do the preparation of the PRF in clinically applicable forms like membrane, plug, so solid forms, or the liquid form. About the blood drawing, we usually use vials of 10 milliliters. We can either use plastic or glass vials. It can be done by a doctor, anesthesiologist, or nurse. Of course, there are different laws in different countries. Generally, the dentists are not allowed to do this blood drawing. And an important thing is that the centrifugation should begin in maximum 1.5 minutes. This means 90 seconds, because otherwise the blood starts to clot, which affects the quality of the final product. Here is a system that helps us to do the blood drawing really fast. And here is a study about the effect of age, gender, and time between the blood draw and the start of the centrifugation on the size outcomes of the PRF. This study was done by Dr. Rick Miron, which is one of the best researchers worldwide about PRF right now. So they concluded that we have maximum 90 seconds, as I already said, interval between the blood draw and the start of the centrifugation. And another thing is that they found that females and older patients produce larger membranes, likely due to the lower red blood cell count. So it's a funny thing that an old lady probably will have the larger membrane. About the centrifugation, so once the blood drawing is finished, we have to transfer the vials inside our centrifuge in a balanced form, which means that every 2 vials should be in antidiametric positions in order for the centrifugal forces to be balanced and not to have vibrations, which probably could jeopardize the quality of the final product. This is the most common centrifugation protocols. The first one was this standard PRF protocol, and the protocol was 3,000 rounds per minute for 10 minutes. But the first most widely used protocol was the LPRF, which is used, of course, till today. And the protocol is 2,700 rounds per minute for 12 minutes, and the final product is solid PRF. It's a clot, a membrane. Then they found out that if we decrease a little bit the speed, this is the low speed centrifugation concept. We will see it in the next slide. We can have, so they found out that we can have a better product if we decrease the speed. So we came up with the advanced PRF, and the protocol is 1,300 rounds per minute for 14 minutes. Again, the product is a membrane. Then they found out again that we have to decrease also a little bit the speed. So the protocol is the APRF plus, 1,300 rounds per minute for 8 minutes. The final product is again a membrane. This is the one that I'm using. And the 2 liquid forms, the APRF liquid, 1,300 rounds per minute for 3 to 5 minutes. The product is liquid. You can see that it's the same protocol, but we are stopping the centrifugation a little bit earlier in order to take PRF in this liquid fibrinogen form. And the IPRF, the injectable PRF, the protocol is 700 rounds per minute for 3 to 4 minutes. Is very useful in facial aesthetics, and of course the product is liquid. Here you can see how the file should be placed inside the centrifuge in antidiametric positions. And this is the low speed centrifugation concept that I was telling you. Dr. Sukrun and his team found out that the dispersion of different cells inside the PRF differs depending on the so-called relative centrifugal force, the RCF, which is given by this complicated formula here. So you can see that the RCF is related to the speed and to the radius of the machine. So if we decrease the rounds per minute, we decrease also the RCF, and they found out that we have a better product. So from the Sucrun standard protocol, that the centrifugation was about 700 Gs, we went to the LPRF, it was around 400 Gs, and after Dr. Ganati's research, we came up with the advanced PRF protocol with even more reduced RCF, around 200 Gs. This PRF has less dense fibrin matrix, more even dispersion of cells, increased number of inflammatory cells and platelets, and a gradual release of growth factors for more than 10 days. So it has increased action. Here is a comparison between these two protocols, which are mostly used, the LPRF and the APRF protocols. You can see that with the LPRF, we can have a larger membrane. This is the membrane, the PRF, but less concentrated. The cells are here at the bottom of the clot. But with the APRF, we can have a smaller membrane, but more concentrated. The cells are more evenly distributed inside the clot. So after the centrifugation, we have three layers of products inside our file. The first one is the acellular plasma layer. Sorry. There's a problem with the presentation. So this is the first layer, the acellular plasma layer. This is the second layer, the platelet-rich fibrin, the PRF. This is what we want, the intermediate layer every time. And this is the last layer, the red blood cell layer. So once the centrifugation is finished, we transfer the files in a special stand, like this that you can see in the picture. We remove the caps from the files, and we have to wait 4 to 8 minutes for PRF's maturation, which means that we have to achieve the clot. Of course, this does not stand for the liquid forms, which they have to be used immediately, because otherwise they will start to clot. So after these 4 to 8 minutes, PRF is removed from the file with sterile tweezers, and PRF is separated from the last layer with sterile scissors, and the cut is made around 2 millimeters below the PRF's lower border. So you can understand that we take a little bit also of the red blood cell layer, and we want this because this junction between the last layer and the PRF is very rich in stem cells, so we need it inside our product. And then we have to transfer the PRF clot at this PRF box, which is a special equipment for the PRF's preparation. Here you can see how we are separating the PRF clot from the red blood cell layer. As you can see, I'm taking also a little bit also from the last layer. And then once we have our PRF clots, we have to compress them for 2 to 3 minutes, and then it is ready to be used. We can either compress them, these clots, with this metal plate in order to prepare membranes, PRF membranes, or we can put the clots inside these holes and compress them with this metal piston in order to prepare the PRF plugs. And it's very useful to use this PRF box because we can collect also this serum that comes after their preparation, and as a result we can prevent dehydration and shrinkage of the PRF products. Here you can see how we are compressing the PRF clots, and after these 2-3 minutes we have the production of the PRF membranes. PRF membranes can be used for many hours after their preparation, at least 3 to 5 hours, but they have to be preserved, as I said, in the serum that comes from their preparation, which we can collect it from the PRF box. You can see here in the picture how we are preserving these PRF membranes. And but the liquid PRF should be used immediately after the centrifugation, because otherwise it will start to clot, and is mainly used as a bone graft weighting agent. So we mix a liquid PRF with our bone graft, and like this we can produce a bone graft with a very solid consistency, and which mainly acts as a bone block. And this is called sticky bone, which is this one here. Some helpful tips here about the PRF's optimization. We have to reduce the vibrations during the centrifugation. We have to fill the files evenly. We have to put the files, as I said, in anti-diametric positions. In patients under antithrombotic therapy, we do not have to prolong the centrifugation process, but we have to leave the clots for an additional 5 to 10 minutes in order to achieve the clot. We have to prepare the PRF clots at the PRF box within the proposed time limits in order to prevent, as I said, the shrinkage and the dehydration. And we can achieve this by protecting the PRF membranes in the serum that came from their preparation until their use. There are many clinical applications of PRF. We can use it in periodontology, in oral surgery, in endodontics, in facial aesthetics, and of course in implantology. I will focus on the clinical applications in implantology today because of our limited time. About its indications in implantology, it can be used in socket preservation. It can be used during the implant placement, during the second stage surgery, in sinus lift, closed or open, in the treatment of peri-implantitis, and during the guided bone regeneration. About the PRF in socket preservation, it can be used as a sole material, membrane or plug, so we can put just PRF inside the post-extraction socket, or in the form of sticky bone, so we can mix PRF in a liquid form with our bone graft, and then as a biomembrane in order to protect the sticky bone. The big advantage in socket preservation is that the PRF can be left uncovered in the oral cavity, so there is no need of primary closure. PRF, by its nature, it's designed to be left uncovered in the oral cavity because it's like a living tissue. It contains cells, and it has also some antibacterial properties because it contains leukocytes. So this is the so-called open wound technique. Here is a systematic review about the effect of PRF on socket preservation. They concluded that we have less dimensional changes and when we are using PRF compared to the physiological healing of the socket without putting anything inside. But in another study, they found out that we have even less dimensional changes when we are using a bone graft. And it's better to use it with in combination with PRF in terms of less pain and better soft tissue healing. Here is a clinical case. There are non-restorable the upper incisors from the lateral incisor till this lateral incisor. So we prepared the sticky bone here and the PRF membranes. I did the teeth extraction, the 4 incisors. The placement of sticky bone inside the post-extraction sockets. And the placement of the PRF membranes. And here some figure-8 sutures just for the PRF stabilization. As I said, it can be left like this in the oral cavity. It can be left uncovered. This is the clinical picture 4 months later. The preserved sockets here in the CBCT's panoramic reconstruction. Again, the CBCT, you can see how well are preserved the sockets here. This is the bone condition exactly before the implant placement. And here you can see that in the vertical dimension, we almost did not lose any bone. And then I placed the implants. Here is the level of soft tissues during the prosthetic phase. And here's another clinical case. Here we have the PRF clots. From them, we produced the PRF plugs. This is the sticky bone. So I extracted the tooth number 47, which is the right lower second molar. I placed sticky bone and then a PRF plug and 1 or 2 sutures just for the PRF stabilization. Another clinical case. Here I would like I would like you to see how I'm preparing the plugs. So I put the PRF clot inside this hole. I compressed them with this metal piston, and the result is these PRF plugs, and this is the sticky bone. So I did the teeth extraction. Placement of sticky bone. And the placement of PRF plugs and some figure-8 sutures for stabilization of the PRF. So about the PRF during the implant placement, it can be used during the immediate implant placement for filling of the bone gap with the sticky bone. And also the PRF can be used as a biomembrane in immediate implant placement and healing with the open wound technique, or it can be used in combination with a healing abutment with a so-called poncho technique. So in this technique, we are doing a small hole or incision in our PRF membrane, and we are screwing the healing abutment in the implant through this PRF membrane. Or it can be used in delayed implant placement. So we can use the PRF membrane or plug inside the implant bed in order to increase the primer stability, especially in cases where we have done over preparation of the implant bed. Or we can wrap a PRF membrane around the implant in order to increase the primer stability. Or we can wet the implant surface with liquid PRF in order to upgrade its surface and achieve a faster osseointegration. Here is a case. I prepared the PRF clots, the sticky bone. Here is the immediate implant placement. Here is the placement of the sticky bone in this bone gap, and I also put a little bit here in order to enhance the buccal plate. And here is the PRF membrane as a bar membrane. Here is a study. They concluded that PRF application increased the implant stability during the early healing period, as evidenced by higher ISQ values. So a simple application of this material seems to provide faster osseointegration. Another study, the treatment of implant surfaces with liquid PRF leads to the formation of a stable and dense fibrin layer in direct contact with the implant surface, thus providing a biomimetic autologous coating, and as a result, a faster osseointegration. Another study, they concluded that the LPRF application during the implant placement may increases the rate and enhances the osseointegration, providing a convenient and affordable choice for implant placement, especially in sites where earlier loading may be required. We can use also PRF in the second stage surgery with the poncho technique in order to promote the biotype thickening and also to increase the quantity of keratinized gingiva. Here is a study that concluded that IPRF may be a first step of non-surgical method for increasing the gingival thickness. PRF can be used also in sinus lift. It can be used as sole material in closed or open sinus lifts, but only when there is simultaneous implant placement, because when we want to preserve this volume for 6 to 9 months in order to place the implants in a later stage, this is not possible with PRF, just with PRF, because we know that it's resorbed after maximum 2 weeks. So it can be used as sole material only when there is simultaneous implant placement. Or it can be used in the form of sticky bone as a grafting material. And the advantage here is that even if a small perforation occurs, there is no risk of migration of the graft particles into the sinus cavity because of the sticky bone's solid consistency. All the graft particles are stuck in this mass, which is called sticky bone. And of course, the PRF membranes can be used for Snyder membranes perforation repair instead of collagen membranes, and as a bar membrane over the bony window in open sinus lift. Here is a study that was done by Dr. Simon Pieri. They concluded that the use of PRF as sole grafting material during simultaneous sinus lift and implantation is a secure and reliable option. And the systematic use of PRF during sinus lift, with or without bone graft, may be beneficial, particularly for the protection of the Snyder membrane. Here is another study systematic review. PRF membranes represent an easy and successful method to cover the sinus membrane or the osteotomy window. another study. PRF can be considered as an alternative material for repairing sinus perforations because it is fully autogenous and easily manipulated. PRF can be used also during the treatment of peri-implantitis. Here is a study. They concluded that the treatment of peri-implantitis with PRF was clinically more effective than the conventional surgical treatment, independently of the defects type. They meant that with surgical treatment that we are cleaning the implant and then we are doing a GBR in order to cover the exposed surface. So in this GBR, if we use also the PRF, the results were better. PRF can be used also in guided bone regeneration. For me, this is the most interesting, let's say, indication. It can be used in two ways, either in the form of sticky bone, so liquid PRF mixed with a bone graft, or as a biomembrane. And of course, it can be used in both horizontal or vertical augmentations. This is the sticky bone. It's our bone graft mixed with the PRF liquid and the PRF membranes. So about the sticky bone, in the past we used to prepare it with by mixing chopped pieces from PRF membranes with the bone graft's particles, but today we are producing it just by mixing the PRF liquid with the bone graft. As we know, for a successful GBR, we must fulfill three basic requirements. The first one is the space maintenance. The second one is the absence of bone grafts micro or macro movement during these healing periods. And we can fulfill these first two requirements just by using sticky bone because of this hard consistency that it has. And then the last requirement is the tension-free primary closure. Then it's up to us to do a very good tension-free primary closure. So all these three requirements lead to angiogenesis, which is a crucial part for a successful GBR. The advantages of sticky bone: it's very easily manipulated. It can be shaped according to the defect. The macro and micro movement is prevented. The space of the grafted region can be maintained, as I said, of course, in favorable defects without the need of bone blocks, titanium mesh, or tendon screws. We have growth factors release, which means acceleration of the healing of the both hard and soft tissues, and this fibrin scaffold minimizes the soft tissue infiltration into the sticky bone. Here you can see how I'm preparing the sticky bone. Here I'm collecting the liquid PRF. I'm just over the red blood cell layer, and I'm collecting the PRF liquid. And then I am mixing it with my bone graft. As I said, we can shape it according to our needs and our defect. We can do it both before and after the hardening of the sticky bone. doesn't matter. And after a couple of minutes, we have this solid graft, the sticky bone, which is like a bone block. So about the PRF membrane, today is acceptable that the PRF membrane can achieve regeneration of both soft and hard tissues, which are under and over it, and it facilitates the angiogenesis in the underlying hard tissue. But there are two main concerns regarding the PRF membrane. The first one is, can we use PRF membrane as a barrier membrane itself? And the second one, if it is used in combination with a collagen membrane, it is placed over or under it. Here's a study. They concluded that the PRF membranes may be an excellent barrier membrane in place of other non-resorbable and resorbable membranes. So the first answer is that PRF can be used as barrier membranes, but how? PRF membrane interacts with the tissues under and over it, and it promotes the induction of a thick and powerful periosteum, which this enhanced periosteum acts later, so after the resorption of the PRF, as the true protective barrier. Here I would like to say that this barrier concept of the collagen membranes, that they prevent the soft tissue ingrowth into the bone graft, today is considered as misleading. It's well documented that we can achieve the same results just by using our periosteum as a barrier. So the PRF membrane can be used as a barrier membrane, but only when no re-entry is expected. And why? Because this thickened periosteum makes the dissection of the surgical flap in the second surgery very difficult. So we have to place a collagen membrane between our bone graft and the PRF in order to make easier the dissection of the flap. So the correct sequence is the bone graft, a collagen membrane, our PRF membrane, and then the mucoperiosteum. So please keep in mind that PRF should always be in contact with the periosteum. Here is a case. After the insertion of the implant, we have a thin buccal plate here. So I placed the sticky bone for enhancement of this thin buccal plate for horizontal augmentation, and then the placement of PRF membrane as a barrier membrane. And of course, then tension-free primary closure. Here is another clinical case. This is the sticky bone. So again, after the insertion of the implant, we had thin buccal plate. So I placed the sticky bone and then a PRF membrane as a barrier membrane. Another clinical case, again, horizontal bone augmentation with sticky bone and PRF membranes. This is the same patient again. So these implants were placed, the two of them, after a closed sinus lift, which I did with the VersaBurst. And in this sinus lift, I put a PRF, some pieces of PRF membranes as a sole grafting material. And here I did also a socket preservation between these two implants, just for aesthetic reasons. So together with this horizontal augmentation, we can see that there are 3 different indications of PRF use at the same patient. I would like to explain now some new protocols that they were introduced in 2019. The first one is the ALP-PRF, the albumin PRF, which is liquid PRF mixed with albumin gel. And here is the protocol. So we take this platelet poor plasma, the first layer, if you remember, and we heat it at a special device at 75 Celsius degrees for 10 minutes. So with the denaturation of the albumin that exists in this first layer, we are having the formation of an albumin gel, and then we are mixing this albumin gel with liquid PRF. The result is a PRF membrane whose resorption can be extended from 2 weeks from the normal 2 weeks up to 4 to 6 months. And another protocol is the bio-PRF, which uses machines with horizontal centrifugation, so no fixed angle centrifugation. So in this kind of machines, during the centrifugation, the files are like this, and not like this, which is the normal one. So with this horizontal centrifugation, we can again increase the RCF at 700 Gs for 8 minutes, and the result is 4 times greater concentrations of platelets and leukocytes in our PRF clots. So I would like to finish and conclude with some take-home messages. As I already said, PRF is a completely autologous platelet-derived biomaterial. It helps us to improve our clinical results. We have to use the appropriate PRF form, liquid, membrane, or plug, and the appropriate protocol according to our needs every time. There are many applications in implantology. We mainly use the PRF membranes and the so-called sticky bone, which is a PRF liquid mixed with the bone graft. And there are some new protocols, the ALP-PRF and the bio-PRF, with very promising results till now. I would like to thank you for your attention. This is my dental clinic here in Greece, in Larissa. You can see my Instagram accounts. You can send me your questions. And of course, tomorrow we have also a live discussion with my friend and an excellent surgeon, Dr. Jaffari. I would like to see you there as well. So again, thank you very much, and please stay safe.
Thank you, Doctor. Thank you for your informative lecture. Dr. Adib, you can start.
Thank you.
I just want to thank Dr. Kouramas for his very informative and interesting lecture on PRF. I don't use PRF at the moment, but I have probably in the near future I start using it. I believe it's going to be very, very helpful when it comes to implants and even peri-regeneration.
Of course.
I believe it improves the results of the GTR and GBR significantly. And I just want to thank you, Dr. Kouramas, on behalf of Confidentes, Canadians, and Bon Offering Payment for this very nice and informative lecture. Hopefully, we're going to hear from you soon, like with more lectures and presentations.
I will be happy. It was my pleasure.
Absolutely.
Thank you very much.
Thank you very much, and stay safe.
Doctor, we collected some questions. We send it to you, and then please report us for our audience.
Of course.
Okay, thank you so much. Thank you for everything. Okay, everyone, thank you so much. We will see you on next webinar. Thank you. Stay safe. Bye-bye.
Bye.
Bye-bye.